Hi, everybody. This is John Lewin, and I'd like to introduce our grad round speaker, Dr. Peter Eby. He's the section head of breast imaging at Virginia Mason Medical Center. He has a long and storied career in breast imaging and has written papers on multiple topics, both interpretive and non-interpretive. And it's very hard to summarize his wide range of activities. He is currently, as I said, section head at Virginia Mason, and he's also a board member of the Society of Breast Imaging. And we are thrilled to have him here. Yesterday, he went on a 20-mile bike ride on the Farmington Canal and had a great time. And last night, he entertained us all at Camacho Garage. So now he's going to entertain all of you with his new focus, which, as he'll tell you, is method of detection. And as it says there, you can text 31274 on your phone to get credit for this. Okay, Dr. Eby.
Thank you. Thank you so much for the introduction, and thank you for the invitation. It's really exciting to be here. I have actually wanted to come to Yale and talk to you about this for months. So it was originally scheduled to try to do this last January, but the Omicron wave had other plans for us. As John said, I am the section head of breast imaging at Virginia Mason, and I'm on the board for the Society of Breast Imaging. I also serve on the ACR's Breast Commission as the chair of the Screening and Emerging Tech Committee, and also I'm on the BIRAD's Revision Committee. And I'm excited to talk to you a little bit about a project that we've been working on with the ACR that is primarily related to breast radiology, but it has implications for other aspects of radiology and other anatomic sections, including, for example, lung and colon and some others that we will get to. And I'd like to begin my talk with a question, which is hopefully thought-provoking, which is why in the United States are we still debating when to start screening and how often to do it? And these are my disclosures. And so what I'd like to do is review some of the fundamentals of the US screening data to try to understand what we know now, and also be able to recognize what we do not know, and why is that the case based on our national data infrastructure and where those data come from. And then talk to you about what we think would be a way to significantly enhance our understanding of breast screening as well as breast cancer care in the United States. So it's a very common cancer. Aside from skin cancer, it's the most common cancer in women. 280,000 new cases in 2021, and 43,000 deaths. Now, lung cancer kills more people, even though it is less common. It is just simply more often detected at a later stage and more difficult to treat. But that number of those expected to die from breast cancer actually continues to go up a little bit every year, despite the fact that we've made significant progress in early detection, which impacts long-term outcomes. And we're going to talk about that a little bit. And these numbers come from SEER as well as world life expectancy. And the randomized controlled trials that were done in the late 60s, 70s, and early 80s, when looking at them in a meta-analysis, confirmed that just the invitation to screening, not necessarily participation, but the invitation to screening did confer a 20% reduction in mortality. And it's really important to recognize that mortality and survival are not the same thing. This means that patients did not die from breast cancer. What you'll also see here on this chart is that there are two outliers. So right in the middle, Canada 1 and 2, the Canadian National Breast Screening Study, Canada 1 being the 40 to 49-year-old group, and 2 the 50 to 59-year-old group, did not show a benefit. But as you can see, there are outliers. And recently, there's been significant revelations about how that trial was run, indicating that it was not a well-executed trial and should not be included in this meta-analysis. And we expect that A repeat analysis without those two included would indicate a greater mortality reduction just from the invitation to screen. Now, SEER can give us some information about what's going on in this country. This is 5-year relative survival. Again, so survival not the same as mortality. And I think it's important to understand that because in the discussions that we have with our internists and family medicine practitioners and some of those who favor less screening less often, they often point to the fact that simply adding a screening mammogram creates lead time, which it does, but that's the point, right? The point is to find the cancer before it's clinically detectable, but that can just increase or improve your 5-year survival numbers, even if the patient ends up dying from breast cancer. So yes, 5-year survival continues to go up, but what's more important is that mortality, where patients instead of dying from breast cancer go on to live productive lives and die from something completely different, is what we are ultimately impacting with screening. And these additional data from SEER, and you can get these are publicly available, easy to see on the website, also show that incidence over time. You can see that there has been a steady rise of about 1 to 1.5% per year in the incidence of breast cancer in this country. That's the top graph. And then on the bottom, you can see is, yes, the death rate or the mortality rate has been going down. Of course, the decreasing death rate is a great trend. The increasing incidence, not such a great trend. And it's the increasing incidence that continues to result in the absolute number of deaths from breast cancer going up every year. Even though, also from SEER, these data on mortality over time. What's really interesting about this graph, which plots mortality from year to year, is that there is an apex to this curve. It is roughly at 1990 to 1992, and 1992 is significant for Congress first signing the Mammography Quality Standards Act, and this is one of the first and only, or very few, federal laws passed to specifically dictate how we perform a medical procedure. Most of you are probably aware that there are very specific stipulations about where the room should be and what resolution the monitors need to be and how often the physicist needs to check this machines, et cetera, et cetera. And so the purpose of this was basically to try to improve the overall quality of mammography in the United States. And what you can see is that after that peak, the mortality rate starts to come down for two groups primarily. So NHB is non-Hispanic Black women and NHW is non-Hispanic white women. And they have both come down, but what you can see is there didn't used to be a gap. And now there is a gap, and that gap is not closing. And overall, for all these patients, the breast cancer specific mortality has gone down by 40%, meaning that if the peak was somewhere slightly above 30 for everybody on average, and now it is somewhere around 20, that's a 40% decrease. And so, as I said, incidence keeps coming up. Absolute breast cancer deaths keep going up and large disparity gaps persist. And why is this? And why can't we, or can we, look at it through our national databases to dial in or dig in deeper into this question to understand it better and fix those problems? And the challenge is that we don't actually have a direct link between screening and outcomes in this country. Which prompts the question of where do our data come from? I honestly did not completely understand the complexity of the data collection process in this country until I started looking into this question. And so I want to talk to you just a little bit about it to help you understand. So there are patients, right? Patients are the ones, that's where we get our data. And they each have an incredible amount of data. Patients who have breast cancer, we would know they would have a size, a stage, there would be treatments, there would be survival, mortality, we would know about race, age, currents, and demographics. And within each of these subcategories are multiple other categories. And these two patients happen to be my mother and my grandmother. And on my mom's wedding day, my grandmother first had breast cancer in the 1960s. She was treated with a radical mastectomy and she lived many, many years. But when her second breast cancer came in her 70s, it killed her. My mother was diagnosed with her first breast cancer in her 50s and had a second breast cancer in her early 70s, and she's alive and well. And so I try to think about each patient as, of course, an individual person, and I can establish or put that link in between my own relatives in this case. So the data come from these patients, and somewhere in some database, I'm sure there are data about my mother and my grandmother. And in our current system, there's an incredible amount of data in the medical record. That includes, of course, the radiology reports, but all of the physician notes, pathology reports, surgical procedures, it's all in the medical record. Now, for that data to get to the public sphere, it goes through a whole host of steps. First of all, the hospital, some local hospitals, whether they be academic medical centers or private or clinic-based medical centers, have their own registries. And each state has its own cancer registry, every single state. And at these registries, there are people, registrars, who abstract data. They literally pour through pathology reports, pour through your radiology reports sometimes, look through treatment plans, and basically fill in empty fields that are required by the registry for every single cancer case. And then that data is ultimately sent off to this organization, NAACCR, NACER. And I had never heard of NACER before. I always assumed that SEER was the end-all be-all of our data system, but it is not, in fact. So NACER, I'm going to tell you about, will ultimately was established in '87, and every single state registry in the US and the Canadian provincial registrars are members, and NACER is responsible for setting uniform data standards, educating and training registrars, certifying all of our registries, aggregating the data, and then feeding it de-identified to SEER. So this is an incredibly important role, of course. Any question or any data that we might want or need regarding cancer in this country is going to come through NACER. Not clinical trials, right? But the population-based data for everything that we get out of SEER comes through NACER de-identified, right? So this is the de-identification step. And then once it's in SEER, right, you can access it online at any time, and there are regular updates. Just checking the chat. Thank you. And so SEER, of course, as many of you are familiar with, is a program of the National Cancer Institute, and it provides us information to reduce the cancer burden among the US population, and it's supported by the Surveillance Research Program, okay? And of course, it includes 18 core registries and 10 research support registries in 26 states, but it's not even 50% of the US population. And you can see there are big states with a lot of people in them that are not necessarily represented in SEER. So for example, Florida, Pennsylvania, Virginia, Indiana, Ohio, Minnesota. These are states with a lot of members. Connecticut is included, Rhode Island is not. But we tend to believe that there is still a representative sample being captured in the SEER data based on this roughly 50% capture. And so it turns out that the NCI staff work with NACER to make sure that all state registries are in compliance with the NACER requirements for what is reported. So that then, of course, those data that get to SEER can be used to calculate cancer rates and look at trends. And so, again, we have lots of patients every day, patients diagnosed with cancer on all of our services, whether you're reading lung cancer screening, CTs, whether you're reading abdomen pelvis, CTs, whether you're reading brain MR, we are finding cancer all the time. But what, again, I am trying to indicate is that because of the complexity of this system and the de-identification process, there are some important data elements that are not directly linked to the patients. And so in the case of breast cancer, there is no field or no place for registrars to indicate in the data capture for a single case whether the patient had a screening mammogram or not, or whether her cancer was found with a screening mammogram or not. And so it is impossible currently for us to link or establish a connection between this single positive or negative data element and all the others that are related to that patient's care and outcomes. And so with that information in mind, it's just a healthy reminder, I think, for me and for others, that SEER data do not represent randomized controlled trials, right? There is no single intervention separating populations into screened or unscreened, right? Randomized controlled trials are basically large-scale recruitments with a standardized intervention schedule and very specific record keeping over a finite period of time, right? A year, 2 years, 4 years, 5 years. There has to be very reliable cancer ascertainment, yes or no. And it's expensive to run a randomized controlled trial, right? And it requires a lot of people in a lot of locations with a lot of resources. And the randomization, however, is considered part of the gold standard, which eliminates bias and makes the trial data reliable. Now, observational research, on the other hand, are also attempts to understand population-based statistics and outcomes without all of the money and the infrastructure and the resources required by a randomized controlled trial. The downside is, because they are not randomized, they are potentially subject to biases related to the way that research is set up. Okay? It still requires reliable cancer ascertainment and ongoing longitudinal data, but this can be achieved by creating a registry that is updated constantly. And so if SEER data are not randomized controlled trials, are they observational research? Yes, actually they are. They are a type of observational research. The three major types are the cohort, case control, the trend, and the incidence-based mortality. And there are some basically different factors that allow us to use these based on the data that we have and the questions that we answer. Now, SEER data essentially are a type of trend study where we can see over time what is happening to incidence, mortality. And so we can compare basically the same nation or the same region from one time period to another. And so with that level of information, we can talk about trends related to incidence or mortality or survival, and we can relate those to other demographics or cancer staging. And that's essentially the limit of what we can do with SEER. And that's important information, but it really doesn't provide any it doesn't provide any connection to how cancer was initially detected. And so without that, what we have to understand is that there's this ongoing debate. Our patient populations are evolving, so they're not the same as they were 30 or 40 years ago when the RCTs were done. Our technology has evolved. We have this disparity gap that is not going away. And without all of that information, we continue to have this debate about the benefits and risks of screening that is really, truly incomplete. So wouldn't you like to make this connection? I would. I hope I've provided a compelling argument for doing it. The question is how? Right? How would we establish for any breast cancer patient, or a lung cancer patient for that matter, if their cancer was detected on a screening mammogram or a screening CT? How can we do that? Currently, the way NACER and SEER exist, we do not have that ability, even though in other countries it does exist. And so if we had that connection, we could start to look at our population in these broader and more varied ways through observational research. So for example, the case control study basically compares a bunch of cases of women who died from breast cancer with controls who are still alive, and then looks at how often they were screened. But of course, this requires that information in the database. And these case control research results, this is basically a table that I lifted from a paper that I did along with Dr. Dooley. Very much appreciate her participation, published in the Journal of Breast Imaging earlier this year, indicating that in case control studies from other countries, Canada, the Netherlands, Western Australia, and the UK, and what we see basically is the odds ratio of dying from breast cancer is, in this case, reduced basically by 49%. In Canada, 49% in the Netherlands, for those women who actually were screened. So it's a significant reduction. And this is something that we can't look at or ask or answer this question in the US. And more recently, then the Western Australia Breast Screening Group also looked at screening and cancer and individual risk factors. And it turned out that the interval cancer rate, or those cancers detected in between screens, was of course lowest in patients with no risk factors or dense breast tissue. And then what they found essentially was that the cancer detection rate across all groups was similar, and that node positivity was similar, indicating that less frequent screening for women with no risk factors was not necessarily a good idea. Now, incidence-based mortality, this is the other type, the third type of observational research, really compares huge populations who participated in screening with those who did not, and all are considered invited or were invited. The problem is that the way this is set up, or the way the question is asked, can be biased by the researchers. But essentially it compares the rates of death in each group and advanced breast cancers, for example. And so these studies are from Canada, Korea, Germany, and New Zealand. And what these countries have in common with the others that I've already mentioned is that in those countries where there is a national health service, and I'm not necessarily arguing for or against a national health service, but where they have a national health service and every woman is guaranteed a screening, they also track with their data whether or not they had that screening and had breast cancer. So their databases are built with this field for screening or no screening, along with all of the other data. And when looking at incidence-based mortality, what we find again is a variable reduction, but all significant, right? Anywhere from 21% to 40% reduction in mortality, or reduced advanced breast cancers, which is also considered, aside from mortality, the next best result. And then a meta-analysis of the European data, again, all with the ability to track screening, finds that in Europe, there's a 38% mortality reduction, Canada 40, and Australia 49. And so these are big numbers, and I think these would weigh heavily on the debate about the risks and benefits of screening. So if we want to make a connection between screen detected or not screen detected and all of these outcomes, if we did do it, what questions could we answer? Now, these questions that I put up here came from some discussion with folks at SEER, folks in the ACR Screening and Emerging Tech Committee, as well as folks at NACER, who all thought about what questions they would want to answer or address, and what actually could be done if those data were available. And so one of the big ones, of course, is what is the relative contribution of screening versus treatment, such as advancing or changing chemotherapy and radiation therapy in reducing the mortality from breast cancer? Or does the treatment of stage 1 cancers detected by screening, should it be the same as stage 1 cancers not detected by screening? Or do patients with screen detected cancers have different treatment or mortality outcomes compared to patients whose cancers are detected clinically? Do tumors that are screen detected have different molecular signatures? Are there specific racial disparities related to screening that we could identify that would explain or allow us to narrow the gap? And of course, what percentage of breast cancers are not initially detected by screening, and how is that related to breast density, for example, direct or risk or other factors? And then, what about supplemental screening options? We do a lot of MRI and ultrasound screening now, and we've definitely shown, the ability to detect additional cancers with these tools, but we would really love to know what else they are doing for our populations so that we could understand how best or who best to target them towards. So I want to know. Do you want to know? I'm assuming our patients would love to know, and I think our physician colleagues would want to know the answers to these questions. So what that leaves us was, how are we going to do it? And so this is the committee that I've been working with. They've done an incredible job to help think about this idea and build a plan and come up with a proposal, and I'm going to share that with you now. So we've been brainstorming and working with stakeholders, including conversations of this with SEER and NACER and others. And what we think is that the cancer registry should actually require state and national databases to include the initial patient-specific method of detection of breast cancer when abstracting the data. I think that's fairly straightforward, but that requires much more effort than you might think. So let's talk a little bit about that. Remember, this is our complex system of data collection, but NACER actually sets the rules. If NACER says you have to include this information, then you have to include this information. And if NACER has it, then it will go to SEER. Now, it's okay if the data are de-identified as long as each patient packet is linked and includes the method of detection. So what we have done in talking to the stakeholders is realize that there are some important requirements and important barriers to be overcome. So for example, the method of detection, if it's going to be abstracted into a database, needs to be findable by a registrar, and that needs to be easy. The registrars are significantly burdened and understaffed, like all of us are. And so even adding a single data element could be too much work. And so the other thing is, if we could do this, of course, then we can answer those questions. And if we can do this for breast cancer, perhaps we could also do this for lung cancer or colon cancer or any other cancer that we currently screen for, either imaging based or non-imaging based. So we would define the initial method of detection as the single first test or sign or symptom that triggered a subsequent workup and recommendation for a biopsy that leads to cancer. There are additional methods of demonstration, for example, other modalities or methods that would also detect the cancer or further delineate the extent of disease. So, for example, a cancer found on a screening mammogram might subsequently get an ultrasound that confirms it's a mass and is suspicious, and then a biopsy done under ultrasound guidance. That ultrasound would be the additional method of demonstration. The screening mammogram would be the initial method of detection, for example. So to ensure data quality, it's important to understand the assignment of the method of detection needs to be prospective before the diagnosis is made. This is what we strongly believe. Once the diagnosis is made and known, there's a potential for a biased retrospective review of the patient path that may or may not lead to incorrect assignment. It needs to be accurate, right? We need to assign the method of detection accurately, and it needs to be easy for the registrators to find, and it needs to be in all cases. And so for the registrars to find it, it should be in a consistent place. And we actually believe that the breast radiologist is going to be the person who knows best what the initial method of detection was, much more easily than a registrar who really doesn't know very much about breast workups and radiology. And so what we would propose is that radiologists really lead the change, like a grassroots endeavor to assign the initial method of detection prior to the biopsy at the time of recommending the biopsy, and simply adding a statement into the report that says the method of detection for this patient is blank. Now, obviously, this requires a little bit of extra effort on the part of the radiologist. But this is how it would look, right? There's your mass, there's the radiologist studying the case and all the notes about it, and then puts in the report, suspicious mass, virus for recommend biopsy, the MOD for this patient is blank, screening, palpable, other. And so then the data would include the method of detection all the way through NACER and SEER. Now, there's essentially three basic categories for initial method of detection. The big one, S, is screening, and this would include any asymptomatic patient. And primarily it would be screening mammography, but it could include screening ultrasound, MRI, et cetera. And then the next big category is patient detected or provider detected. The difference being self-exam versus an in-office clinical exam. And then, of course, there are rare instances, at least in the breast cancer world, where patients are diagnosed outside of either of these two. For example, presenting with bone pain, getting a CT, and finding metastatic disease on a bone biopsy, for example. That would be what we would call a none of the above or other type of method of detection, which would be rare. And if we can expand these subcategories to include 2D mammography, so no synthetic view and no DVT at all, or screening with any kind of DVT with or without full field 2D or synthetic, and then of course screening, ultrasound screening, MRI. There are now of course programs that are using contrast enhanced mammography, and then there are nuclear medicine screening techniques as well, and there will be others probably. There are definitely others in the research pipeline. Of course, what we would be really interested in is SMA and SDVT would be the primary tools. And then of course, we'd love to know if patients are detecting their own cancers and how, if there's some pattern or additional demographic trend that we can identify within those versus whether or not a provider does, as there is also a debate about whether or not patients should be doing their own self-exams or providers should even be doing clinical examinations. There are some groups that recommend neither of these things, whereas there are many groups that still recommend both. sometimes it's difficult to tell if the patient was the first person to detect it or the provider. In which case, we may have to leave it at both. And so what we would suggest is that the MOD would be assigned whenever a patient without an active diagnosis of breast cancer was recommended for a biopsy. So a 4 or a 5. This includes when a BI-RADS 3 would be upgraded to a 4 or 5 if the finding grew, for example. And when not to MOD was if the patient already has a diagnosis of breast cancer, don't add an MOD. Now, presumably, the MOD would already exist from a prior report, so don't add another one or a different one. This also includes when the MRI is for extent of disease for the same reason, because the patient already has a diagnosis. And we wouldn't usually add an MOD to an interpretation of an outside examination, because again, the patient already has a diagnosis of cancer, and presumably, or hopefully in the future perfect state, they would already have an MOD from the outside. And so what we're suggesting is BI-RADS Atlas was the first of its kind, and really developed into something that was adopted nationwide and internationally. It also has set the example for other atlases, LIRADS, TIRADS, PIRADS, ORADS, et cetera. That we would apply or ask for this MOD inclusion similar to the way in which BI-RADS was originally instituted. And so we actually have sites that are piloting this. Duke, George Washington, Northwestern, Pittsburgh, St. Bernard's, of course, Virginia Mason and Washington University. Stanford is wanting to join us. And there are some other institutions that are slowly beginning to trial this process. We currently have talked to and are gathering support from other organizations that are related or involved in the treatment of breast cancer patients, such as the American Society of Breast Surgeons, the American Society of Clinical Oncology, and then EPIC actually has been supportive. So in developing the pathway for recording MOD and including it in databases, some people report in EPIC, and the national EPIC team is now fully supportive of this. And so anybody who's using EPIC, I can put you in touch with the EPIC team to help create the electronic placeholder for MOD. We've talked with NACER as well as the National Mammography Database, where they have actually now included the MOD field as an optional field. The Breast Cancer Surveillance Consortium is also in our discussions, as well as the Commission on Cancer from the American College of Surgeons. And these are the pilot data that I recently presented at the NACER Summer Forum in June of this year. Basically, what we did is we've been adding MOD to reports for over a year now. And we've gone back retrospectively to look at our cases of cancer to see, was any MOD in the original report, number one? Was it correct, number two? And then we created a placeholder within our registry to see if the registrars could find it and transfer it from the radiology report into the database. And it's difficult to see the numbers here, but 90% of the time we did actually include an MOD in a report. 94% of the time it was correct. And I think this is 86% of the time it got into the database. And this is pilot data at a single institution for now. But what we think it indicates is that this is feasible. There's certainly room for improvement. We would love, of course, this to be 100% across the board, which is never going to be achievable. But hitting in the 90% range early on, I think is very encouraging. So to summarize, there are vast amounts of data within SEER, and it is an incredibly valuable resource. It does allow us to understand many things about cancer in our country, but there are some things that are still not directly linked from patient to outcomes. including the initial method of detection with regards to breast cancer, which is included in databases in other countries around the world. If we were able to add this field accurately, there are many, many questions that we could dig into, that we could truly ask in an attempt to understand more closely what's the cause of some disparities. What's the relative contribution of screening versus treatment? And how we might then go about changing these things to benefit our population. And we think that radiology is the team in this particular case who are the experts, who have the history of leading grassroots initiative, who can actually create this solution and then build it into what we do with minimal additional effort. And so with that, I do want to thank some of the folks who are at some of these database companies who are not companies, but organizations who have spent time on the phone to explain to me what registries are about and how they work. And of course, registrars who are in the weeds, basically pulling data out of the lengthy reports that we create. They've been incredibly valuable to us to understand how this process works and what solution might work in a collaborative way for everybody. So I'm really curious about what you think about this for breast, but also non-breast applications. And I'm very much interested because I think it's a process that probably we are going to or could develop and own. And I'm always interested in the perspectives of others when it comes to this. So I thank you so much again for the invitation. I really appreciate it. I'm so glad I finally got to share this and talk to you about it. And I would be happy to take any questions from the audience.
So thank you, Peter. That was great. And I'm sold. I'm all for it. So if anybody who has there's a question online. So Peter, you have the mouse. Why don't you click on it? So yes, select any questions. So that's our chairman, Dr. Goodman. And he says, well, you can all read this. Would there be any merit to distinguish between cancer detected by a comprehensive screening? So, as in many European countries, as opposed to intermittent screening, or what we call, whatever it is.
Yeah. No, I think it's an excellent question because I think what it leads to is, or what you're asking and what we could try to understand is, if patients were getting screened every single year and a cancer was found and it was reliable every single year, then we would have, that would be different information than somebody comes in 2 years and then 3 years and then 1 year and then 4 years, which are different intervals for cancer to develop. And how would that different interval impact or be related to outcomes is also important, because we do definitely debate the interval, right? In the UK, it's every 3 years. Most of Europe, it's 2 years. In the United States, the ACR, as well as the American Society of Breast Surgery and ACOG, say 1 year. American Cancer Society varies between 2 years and 1 year. So obviously, Dr. Goodman he listened and understood. This is the one thing that we haven't been able to quite specifically address with our plan. The timing of the last mammogram or the interval since the last mammogram. We don't have a great way in the moment to capture that.
Okay,
and I'm open to ideas or suggestions.
That's obviously key, because that's a huge debate, as you said, is what often we should screen. So yes, opportunistic screening is the opposite of centralized screening. Yeah. That's basically what we have here, even though we have recommendations.
Right, because in those other countries, they send out the invitations to every single woman, because it's all covered for all of them, at exactly the same interval, and they track all of those, right? So we don't have that sort of national level regular invitation. Obviously, we have public hospitals and private hospitals, and we have imaging centers, and we have universities and academics and all these places, and we have private insurance, and we have federal insurance, and all of these things are done differently. And so we don't have that national consistent framework for logging the time period between screens.
Yep. So any other questions, type them in to the Q&A or chat if you want.
I have a question. So that was great, Peter.
Thank you.
It's a tremendous amount of work and a really important initiative to, determine the value of the screening that we do, and to also take into account the technology and variable screening modalities. So in an ideal world, when do you think we will have this in place? And has NASA been really receptive to including this? That's the one hurdle I know that you and the committee were working on.
Yeah.
And then assuming that they are receptive, do you think, 5 years that this will be in place? Will this be, 2 years, it's gonna be maybe it's gonna be the new BioRads, so it'll be socialized to everyone? What's the goal and the sort of the outline for this?
Yeah, I love this question too, because when we started this project, we thought we would do this in 12 months, which was incredibly naive on my part. But I think actually it was helpful for me to think that it was so easy, because otherwise I might have given up early. So I think so NACER has been really excited about this. The registrars understand the value of data, and it's really interesting to talk to them. If you've never met any of your registrars, I would really encourage you to call one up or walk to wherever they are. I'm sure you have a registry within walking distance of here, right? They get really excited when clinical questions come back to them related to all the work that they do to pluck these data out of the reports. So NACER's been supportive. They like this idea. They want it to work. And they want it to be really easy for their registrars. And so they were excited to see that we actually had pilot data. They said, well, when it can't do anything until you've shown us that it can be done, number one. So now we have pilot data. They actually have a form for adding elements to the registry that you have to fill out, and then it goes through their committee. I did it last year, and they came back to me, thankfully, with a whole bunch of feedback, which was great, including getting this pilot data. One of the things that I'm trying to do right now is schedule a follow-up call. Okay, now we've published, or we presented at your meeting, we still want this. What else do you need to see from us? What else do we need to do, right? I think it'll probably still be a year or two before they fully buy in. The National Mammography Database has included this element as optional, as I said, in their data dictionary, and I am working to include MOD as basically a new optional field in the virus atlas. The key there is that once it's in the atlas, then software vendors have to take note of it, so that those vendors would potentially add the MOD field to the reporting systems, which might make it even easier for radiologists to just click a box. So it's still a few years out for sure. But there's definitely more people who are trying it out, and I think we're going to learn more about how well this works in that time span.
How many elements are there right now in breast cancer?
So in the oh wait, what, I'm sorry.
For breast cancer, how many elements does the registry have to report right now?
Oh, many. So they have to go in and pluck out the size of the cancer, the receptors, whether or not the patient was offered radiation therapy, chemotherapy, they have to pluck that out of right, the med-onc and the rad-onc reports. So they spend a lot of time abstracting these cases, which is why they're very hesitant to add things, because they're already very, very
busy.
yeah.
Go ahead. So Dr. Marla had a question about, how do you know what's screening, what's not? So patient came in for diagnostic, but if you find a cancer and, in the opposite breast or otherwise.
Yeah, that's a great question too. So I love this, that I've had 2 questions from 2 people and they have dialed into the little tiny critical details of this. So this would still be called patient, PAT. And I'll tell you why. It's because, again, if we follow the definition, which is what was the thing that initially brought this patient to our attention? It was, in this case, the lump or the discharge. And so that's considered diagnostic, even if she's been 2 years since her last mammogram and you add the CC and MLO views for the contralateral asymptomatic breast, and that's the one that actually has the cancer. It was still the patient that brought herself in this case. And so that would still be considered a patient detected cancer and not a screen detected cancer. Because really what we really want to know, the most important question is we want to know what is the value of screening in the asymptomatic population. And so we want those cases to truly be pure screenings. I hope that answers the question.
Yeah, I think so. That's very good. Well, thank you. Any more questions? Hurry, type them in. Otherwise, we have a gift for Dr. Eby.
No.
And it's right here.
Is it okay?
But we that's right. Here you go.
Oh, you guys, thank you so much. Wow. Can I open it now?
Sure.
Oh, Yale Radiology. It's not just Yale, it's Yale Radiology.
Yale Radiology Yeti cup. We have a camera on
Do
this.
you know how much coffee I can put in this?
Yeah, that's not for the.
All day and I see.
That's not for espresso. That's-
This is incredible. Look at that. That is quite, is there, thank you so much. Oh, and a shirt?
And there's, yes.
Oh, that's beautiful too. Thank you so much. I really appreciate that.
Absolutely. Thank you for coming.
Thank you. We appreciate it.
Really, my
Great.
pleasure. Thank you for the invitation. If you have other questions or interest, you can contact me anytime.
All right, thanks.
Enjoy your day.